right, we're going to get started. Emily, you think we're ready?
Yes, I think we
Great,
should be good.
wonderful. So I'm Alice Casey. Marion Ryan is going to be joining us. She'll be here shortly. But in the interest of time, we're going to start off. We're really grateful. We have some wonderful speakers today. We're going to start with Dr. Liz Evans, who's a professor of public health and chair of the Department of Health Promotion and Policy at UMass Amherst. For more than 2 decades, Liz has investigated how healthcare systems and public policies can better promote health, wellness over the life course, with a current focus on justice-involved individuals with opioid and other substance use disorders. Currently, Liz is the principal investigator of Mass JCOIN, the Massachusetts Justice Community Opioid Innovation Network, a 10 million research hub assessing the implementation, outcomes, and costs of providing medications to treat opioid use disorder in Massachusetts jails. Liz is also evaluating several federally funded programs being implemented in Western Massachusetts, including court-based programming to link people to behavioral health care and social services, and a program to offer trauma-responsive, gender-sensitive addiction treatment in carceral settings in Franklin County, funded by Substance Abuse and Mental Health Services. Liz has authored more than 100 scientific publications and government reports. She's a member of the Massachusetts Public Health Council, where she advises the Department of Public Health on major policy decisions. UMass has recognized Liz as a distinguished community engaged researcher and spotlight scholar. Thank you very much for joining us. I turn it over to you.
Thank you. And thank you for reading that very long bio. I probably need to shorten that. So thank you for inviting me. I'm excited to share some of what we've learned from a study that is sort of wrapping up. And it's my first time joining this opioid task force. So I'm very much open to questions as we go along or towards the end. I did prepare these slides that, are probably going to be 15 minutes or so of a presentation. So I'll display it now. Hopefully everyone can see that and you can hear me okay. Okay, so yes, thank you for the warm introduction. I'm going to focus on that Mass JCOIN study. So we've been studying delivery of medications to treat opioid use disorder inside the jails in Massachusetts for the last 5 years. And we have some results about the outcomes of that big program. And so that's what I'm going to share today. I work in partnership with Dr. Peter Friedman, who is a physician and addiction scientist at Bay State Health. I think he's going to try to join today, but he maybe had a conflict. There's so many people on the Zoom. I'm not sure if he's here. So if he's here, hello, Peter. So I'm going to jump in. You all maybe know, but in case you don't, back in 2018, a new law passed in Massachusetts called the CARE Act, or Chapter 208, and it created this legislative mandate that required jails in Massachusetts to implement a pilot program to offer all of the FDA-approved medications to treat opioid use disorder, or MOOD, starting in September of 2019 and going forward. And the law stipulated that for people coming in to a jail on medication already, jails needed to continue that medication. And for people who had opioid use disorder and were entering jail, but were not yet on a medication, jails needed to offer the opportunity to induct them onto the medication within 30 days of their release. And so that's sort of the bare bones of what the law required. These jails in red stepped forward to say, like, we would like to be a part of this pilot program. We want to try this out and see what's possible to implement. And from this, we can learn, whether this is worth doing maybe more broadly. So this law happened. And when we learned of it, it's like, oh my gosh, what a great opportunity to study all of this. And so we did ultimately were funded to study this big change in policy. And I want to point out Middlesex was one of the first houses of correction led by Sheriff Katusian and his staff to say, we want to be the one to help pilot this and contribute to scientific knowledge. So I'm not sure if he or his staff come to this task force, but he's been a great partner in enabling this research to go forward. So thank you for that. So just so you know, the study was funded by the National Institutes of Health, NIH, the institute called the National Institute on Drug Abuse, NIDA. And we have four aims. The first one, oops, sorry, is this longitudinal treatment outcome study. So we want to know, people are entering jail, they have OUD, opioid use disorder, and some of them are receiving these medications, and the three different types are available to them: methadone, buprenorphine, or naltrexone. And some people end up getting nothing. They might choose not to get the medication, or there are other reasons why they might not be eligible for it. So we want to know, what are the differences in outcomes depending on the type of medication that they received. And our outcomes are being measured after release from jail. So the primary outcome is whether they continue to receive medication after release, and also these other secondary outcomes like overdoses, mortality, use of the emergency department or other hospital utilization, and recidivism as well. So rearrest or reincarceration. We had other aims. I'm going to focus on the results from aim 1 today, but just so you know, we also studied the implementation of, this was a big change. Jails had to organize themselves to offer this medication and to deliver it, according to evidence-based practices. And so for aim 2, we studied the implementation of the program, all with an eye towards, can we distill lessons learned and maybe create a playbook for jails elsewhere on how to implement a program like this one. There's an economic aim as well, where we're looking at the cost of delivering this program and is it offset by any savings down the road. And so that's happening now. And then we were later, more recently, funded for this fourth aim, where we're following a cohort of people and interviewing them like in person, or over the phone. So I'm going to focus on the aim 1 results. I think that's what you're most interested in today too. And these are sort of like hot off the press. It was just generated this summer, and presented in a legislative report that went to the Massachusetts legislature in June. So to measure those outcomes that I mentioned after release from jail, we partnered with the Massachusetts Department of Public Health, another great collaborator led today by Robbie Goldstein, and Dana Bernson is our collaborator there. And you may know, in Massachusetts, there's this great resource for research around the opioid epidemic called the Public Health Data Warehouse. And so that warehouse receives data from institutions in Massachusetts, like jails or hospitals, or all of these things you see here listed in all these boxes, is just to visually show you the Department of Public Health receives data on every adult, I think age 12 and older in Massachusetts, who interacts with these institutions. Their data gets put into this warehouse. It all gets linked together individually such that we can follow individuals backwards in time and forwards in time to see how do they interact with these institutions and what happens to them over time. So it lets us study things like overdoses or use of the hospital or recidivism. You should know that all the data is protected. It's many safeguards in place, like it's stripped of all the identifiers. So ultimately we cannot know the identity of any person. Instead, we're able to analyze data in a way that protects people's right to privacy and confidentiality. Anyway, I'm just highlighting here how this was another great collaborator that enabled us to study outcomes on everyone who was being released from all of the jails in Massachusetts who were part of the study. So that's a great design strength. Yeah, do you have
Yeah.
a question, Alice?
Can I ask quick? So you say institutions. So what institutions are covered when you say that? I mean, this is really fascinating.
Yeah, and they have their own website. You can go and I can make sure you know where it is. But it is things like, so through our JCoin project, we assisted all of the jails in Massachusetts to share all of their data with the Public Health Data Warehouse. Prisons share their data as well. Hospital systems share their data. If anyone's transported by like an ambulance, that data gets shared. If there's an overdose event, that gets shared. Death records, birth records. They also now pull in some data like from the Veterans Affairs Office. The Department of Mental Health shares their data. So it's this amazing resource. Yeah, I'm surprised it's the first you've heard of it. It was also created through a legislative mandate in Massachusetts in 2015. So it was created then and has been made available for research purposes, really since then.
I've definitely heard of it. I just didn't realize, what the collecting source was. So thank you very much for
Yeah, yeah,
for
yeah. And
Informing.
Yeah, it's a model for other states are trying to do what Massachusetts is doing. It's a real way to like just uncover new knowledge about the opioid epidemic. And Massachusetts definitely is on the forefront of creating data like this. Okay, so we worked with the jails in Massachusetts to know inside of your jail who is likely to have an opioid use disorder, starting from 2019 going forward. And today I'm going to show you results on everyone who exited jail between 2019, September 2019 and December 2020, who was known to have an opioid use disorder when they entered jail, and that they exited or were released from jail by July 2021, such that we had some follow-up time. Like we wanted to observe them in the community after they were released from jail for at least 180 days. So that gave us about 6,383 people. And of them, 42% received the medication while they were incarcerated and 58% did not. And so the graph on the right just shows you a little bit like how did we get to this sample size, but it's a pretty large sample size. It is large enough to enable us to do our analyses. And so a reminder, this is everyone with a probable OUD exiting our jails, 7 jails in Massachusetts in this time frame, who we could observe over time. Um, and I say probable opioid use disorder because it's just important to note every jail diagnoses or learns of someone having an opioid use disorder in different ways. And so here we listed our 7 jails by number and the different ways in which they detect whether someone has an opioid use disorder, just to highlight how there's variation here that we just need to acknowledge. It's a potential limitation of the study. Some of it's based on self-report, like the person says, I have opioid use disorder. That's often verified through biological testing or a pulling of records through the prescription drug monitoring program and other ways. But anyway, this is an area for us to focus on in the future. How do we maybe standardize diagnosis of opioid use disorder when people enter jail? And then you should know the Department of Public Health creates this thing called an OUD algorithm. So they have all these indicators using those databases I just showed you that get linked together to identify also who probably has an opioid use disorder, because they've seen based on that data, this person has had an opioid overdose in the recent past, or they have a diagnosis of opioid abuse or dependence in their medical records, or they've received treatment for OUD. And so there is this second way of knowing who has an opioid use disorder. So we used both ways in our study, just so you know, to try to like be sure we could detect everyone who is likely to have an OUD who's in jail. And so for the rest of these slides, it is going to be all the outcome information, just reminding you our outcomes are the use of medications to treat opioid use disorder after jail release, within the 180 days after jail release, whether they were reincarcerated in jail, overdose events and mortality events. We use this other method called propensity score weighting to adjust for differences among the population of who got the medication and who did not in jail. So this is not a randomized clinical trial. We didn't like flip a coin and assign people to you get medication, you don't. So there is like this idea of self-selection. Some people got medication or not based on these characteristics you see below. And we know those can be related to outcomes. So to account for that, we do this thing called propensity score weighting to adjust, like try to make the groups very similar such that the only thing that makes them different is whether they got medication in jail or not. And I can talk more about that if people are interested. This is the differences in the characteristics of people when they were entering jail, according to whether they got the medication, MOUD, or not while they were in jail. And you can see there were differences in the population. So, for example, people who got medication or mood, more of them were sentenced and fewer of them were on a pretrial status, which kind of makes sense. Like sentenced people are in jail longer. So maybe there's just more opportunity to offer them the medication and get them on a treatment regimen before they get released from jail. Another way in which they were different is people on the mood program, they were in jail longer, 51 days versus 71 on average, or that was the median. There was also differences by race and ethnicity. So people who were white were more likely to receive the medication while in jail than people who were Black, non-Hispanic. And so this really underscores a potential racial ethnic difference that could indicate disparities in access to healthcare that we're interested in examining. And then for the most part, the populations were very similar to each other. You can see the characteristics here, but I'm just highlighting some ways in which they were different. That's important to take note of, and underscores also the reason to do that propensity score weighting that I mentioned. And so this is just showing data to illustrate, for those of you who are interested, like how does propensity score weighting create two populations that look similar to each other statistically before they get weighted or controlled on those characteristics. Those are the blue circles, and anything outside of the middle range there means that the two groups are different. But once we weight them or use the propensity score weighting, those are the stars that are like in orange. Now the two groups become very similar. And I'm not going to spend too much time on this, but just so you know, like the propensity score weighting process did work as expected. So here are the results. Everything here is about people treated with medications while in jail had what after release compared to people who did not receive the medications while in jail. And the text on the left summarizes the statistics on the right. And the statistics on the right, each line is an outcome. So let's just talk about the first one. Did they get medication for opioid use disorder within 30 days after release from jail? Anything, see the line in the middle of this box, anything to the right of it means they were more likely to have that event. And anything on the left means they were less likely to have that event. So if we put it into words, people who got medication while treated in jail were 3 times more likely to continue to receive that medication in the 30 days after release from jail compared to people who did not get medication in jail at all. So we could do the second one, reincarceration. People who got medication in jail were less likely to become reincarcerated 180 days after release from jail compared to people who were not treated with the medication. And they were also less likely to overdose. So these are all very positive outcomes. People who got the medication in jail treatment were more likely to continue that treatment in the community after release. They were less likely to become reincarcerated, and they were less likely to overdose, is what this all means. We also looked at overdose events, fatal overdose events. And so this is sort of like they were, people treated in jail were less likely to have a fatal overdose, but it wasn't statistically significant, meaning there wasn't a difference between the two groups that we could detect. It was in the right direction that we expected, but didn't reach statistical significance. As for all-cause mortality, the program did reduce overall mortality, and this was a significant difference. So people were less likely to die of any cause after release from jail if they received the medication while in jail compared to people who did not receive that medication while in jail. And we're almost wrapping up here on the results. We want to acknowledge limitations, which I noted up front, that there was this, we had to do some footwork to detect who had opioid use disorder in jail. We used these different methods. We think we did a very good job, but there's the chance that we missed some of the people who had opioid use disorder who were in jail and weren't able to be captured in the study. There is this variation in access to medication in these communities. These counties, they're all very different. And so when people get released from jail, they have different availability or accessibility to medications in the community. So we weren't able to control for that variation. There were some challenges with like matching our data, but again, we think we did a pretty good job there. And then of course, COVID-19 happened, like soon after this all launched. So we weren't able to control for that. We're acknowledging that that happened as well. And still, though, we found these very promising outcomes despite this like other epidemic happening at the same time. So we conclude that jail-based mood treatment is associated with higher rates of post-release use of mood in the community, lower rates of opioid overdoses, lower rates of reincarceration, lower rates of all-cause mortality, We did see these racial ethnic disparities in access that merits further examination and maybe an intervention. Like, how can we support people of color who are incarcerated to access and use these medications more than they are currently right now? And this required a huge team of folks in all of the houses of correction and across several different academic and governmental institutions. Thank you to everyone. This is not all the names, but a lot of them. And as I mentioned at the outset, all of this was shared in a legislative report to the Massachusetts legislature in June. You can read the full report here. I put the link, and these slides can be shared afterwards. We also generated many publications that you can read if you scan these QR codes or go to this link. It's a library of our publications that also share like what we learned from the AIM-2, the implementation, like how do jails implement a program like this is a lot of what's in here, and some other findings that we're sharing. And we're right now working on our next steps, which is to publish what I just shared with you, and also to respond to the next call for proposals for a JCoin phase 2 clinical research hub. So we're working up some ideas focusing on how to increase continuity of mood in the community after release from jail. If you remember, about half of people continued to receive mood when they were released and half did not, approximately. So how can we improve that will be the focus of our next proposal and body of work. It's being worked up now. It's due in January as a proposal. We are a part of a national network of hubs around the country that are doing work on the carceral legal system and how can we address the opioid epidemic there. These are the priority goals of that national network, one of which is to create capacity to do this type of work and collaborate, form collaborations between researchers, community partners, governmental officials. And so you should know Massachusetts is one of those clinical research hubs, but there are 13 others and generating a lot of evidence. You can go to this website at the NIH HEAL Initiative and get a lot of information being generated on these very hot topics. And you can also go to this website, jcoinctc.org. There's a lot of free webinars and podcasts and sessions, lots of information available to everyone in the community. And that's it. I want to thank you. I kind of sped through that, so I hope we, though, have time for questions or comments.
Dr. Evans, thank you. That was great. People
Thank
have
you.
questions, comments?
Liz, I have a question, Alice Casey here. In terms of this,
If I'm not seeing your hands on a different screen, just speak out.
Okay, Alice. Alice is speaking, I
thank
think.
you, thank you.
Yeah.
So
All right.
can you remind
Thank
me?
you. Thank you very much.
I can put it in the chat, Liz. The
Morning,
question.
everybody. I'm sorry to be a bit late, but I want to, just before we go to our next speak. I'm sorry. Does somebody have a question?
I was going to ask a quick question. I can put it in the chat. That's all fine.
No, that's okay. Just ask. Go ahead.
In terms of the methadone that was accessible for folks who were incarcerated and the buprenorphine, were both of those substances available when the study started, or were there any changes in what was accessible?
Yeah, that's a great question. So jails did focus on offering all of them as soon as they were able, but each jail brought in each medication at a different time point. So some jails were able to offer all three almost immediately. Others had to work to get a vendor, especially around methadone, and it took them a little bit of time. But I would say I could look at the dates, probably within the first 6 months of implementation, all jails were offering all of the medications, either because they had created a clinic and they were offering it there through a vendor, like they brought in a vendor to offer all the medications, or they themselves, the jails themselves became an opioid treatment provider. So that's a great question. There was a little bit of a staggering of when each medication was available, and that was different by each jail. But now all the jails do offer all three medications.
Thank you.
Yeah.
Jacqueline, did you have a question, Jacqueline?
Yes. Was data collected on the success or not success rate of the individual medications that were given, or was it just grouped together all as one?
Yeah, we did look at outcomes by medication type. So we are in the process of like finalizing that more refined analysis. So that will be coming out in the upcoming months. There was a difference by medication type, I can say. I don't want to say more. And in general, based on my knowledge of all this, I do think it's important jails offer all three medications types because people have different needs. And so it's important. A question though is like, how do you better match medication to each individual? That's very challenging and requires like medical oversight and can change over time too. So that's a great question, and we'll have more information on the results soon to share.
Okay, thank you.
Yeah.
Thank you, Doctor. Anyone else? All right. All right. Well, thank you so much. Before we go on to our next speaker, I just want to welcome everybody. Obviously, I'm sorry I was a little technologically challenged this morning. And beginning, as we always do, with really recognizing the work, really the groundbreaking work we've been able to do in this county is because of the partnerships we have. You know, it's coming up now on 13 years that we've had this task force going. We have met every single month through the pandemic and through these changes. And right now, we are seeing even more dramatic results than we've seen in the last few years. And we're being really recognized nationally for some of the things that have happened here. But I am convinced that it is partnership. When you keep bringing the same people together and the people who have a real stake in all of this. And really evidence of that, I want to especially welcome this morning. We're fortunate to have Medford's Mayor Brianna Luongo-Kearns here, Malden Mayor Gary Christensen. You know, these are folks who have lots on their plate, and yet they make time to be here for these task forces because we really are committed to making a difference, to changing the way we look at this problem. And I want to begin, as I always do, by talking a little bit about the numbers and knowing that, and everybody's heard me say this so often, even one death is too many. But if you think about just the fact, in a very conservative estimate, that everybody who loses their life, that death affects 10 people. Now, we know it's going to be way more than 10, but just think about that. And then think about where we are in terms of numbers, and with your help, where we've gotten to. This year, from January 1 of 2024 to just November 1 of 2024, we had across this county of 1.8 million people, 113 non-suicide opioid overdose deaths. That reflects a 30% decrease, flat 30% since the same time period, January to November of 2023. That is that many people who don't lose their life, whose families don't suffer, and the impact again on that circle of folks. That number is well above the statewide average. And as I said, it's really leading to lots of folks reaching out to us to talk about what is it that we're doing to get to that really promising statistic. And another piece of it that we know has played into all of this and that we are very committed to is not just the destigmatization in general, but increasing folks' use of Narcan, the xylazine and fentanyl strips that we have. And I say this all the time, I buy lots and lots. My goal is not to ever have it sitting on a shelf. So if anybody needs it, we are happy to get that to you. We are also, as many of you know, going to refile a piece of legislation to make sure that that copay for Narcan, which people think of it as pretty ubiquitous now, and you can get it without a prescription, and you can get it lots of places. But if you maybe want to be a little more private about your medical purchases, there is still a copay for some insurance companies. Some of the bigger insurance companies have moved to making that not be a factor. But that copay can vary greatly depending on where you get your insurance. And we have unfortunately seen those cases where not having the cash to do the copay after somebody has used it, you know, you can't ration the Narcan, you have to use it, you use it, and then you need another one. And people may be waiting a little bit because they're trying to put the cash together for that copay. and then needing it and not having it. So we filed a piece of legislation 2 years ago that would create a fund where anybody manufacturing or selling opioids in the Commonwealth would contribute literally a fraction of a cent for every sale or manufacture to a fund that would reduce that cost. The goal is New York was able to get their copay down to between $5 and $7. And that is really our goal with this legislation, to be able to do that. The other thing that we're really looking at is some of the creative things that some of the cities and towns have come up with. Like, for instance, the city of Newton has piloting an naloxone box, which is the Narcan in a box in every public building, including the library, the town hall, all of those sorts of things. So that's just a really creative way to have it out there. Some of you will remember we had some Harvard students speak at the task force a bit ago who are really successful in getting some Narcan into some of the T stops so that it's available there and, you know, just hanging on a wall or something that people can use. And also, we want to make sure if people don't just have it, they know how to use it. So we continue that education last week. And I know, I think both Medford and Malden had folks here that we had a lot of people, the school nurses come in to do education for them. Dr. Dan Muse, who many of you have met through the task force, who was just so generous with his time, came up and did a program for that. And we really were trying to push with the nurses, you know, it's not just the medical professionals. We want everybody to be knowing about that. The studies indicate that that education is working. The most recent study on this issue shows that when law enforcement or fire rescue are responding to an overdose, in over 43% of the cases now, somebody has already given a dose of Narcan, whether it's a family member or a stranger. So that is working to get that out there. You know, I just ask you to, you don't have to raise your hand for this, but just think about it. We should all have one in our purse. You know, throw one in the glove compartment of your car. You just never know when you're going to be someplace that you need it. And again, we're giving it out for free. So we are happy to do that. We are also continuing to look at the contamination piece, whether it be fentanyl or xylazine. And we know that the presence of either of those can interfere with how effective the Narcan will be. So even if you have the Narcan, if you've got xylazine or fentanyl on board, the Narcan's not going to work that well. And just 2 weeks ago, the United States Department of the Treasury sanctioned the leaders of La Linea, which is a really violent Mexican drug cartel. And they've been bringing an enormous amount of fentanyl into the United States. And those financial sanctions, that's a new move by the government to really try to make it hurt for drug traffickers in the cash department. And it seems to be an effective way of trying to limit some of that, especially for those who are doing crypto-dominated fentanyl sales. And that is a growth industry. And that fentanyl is coming here. The other place we're seeing it is we have seen in a number of our towns, Cambridge, Everett, Framingham, and Reading, most recently, people using pill presses. So they're mixing things up and then producing these very nice professional looking pills, but somebody, and they even have stamps and numbers on them like regular prescription pills, but you have no idea when you buy or ingest those what might have gone into that pill press. So they're mixing up a batch of whatever, throwing it in the press and cranking out some pills. So we're trying to be very focused on those, really in looking at sentencing or people being held around folks that we find that have a pill press. They're not doing that for themselves. They're cranking out pills and they're putting them on the street. So that's really part of what we're looking at going forward. So I think obviously there's lots of work to be done. As I've mentioned many times, as our numbers have gone down, what we have seen increase are those cases where we have an opioid death, which is a death by suicide. And remember, we have a very high bar for calling something a death by suicide. So there has to really be an absolutely unequivocal indication that that's what it was. And even with that high bar, we continue to see that number going up. So we're very focused on that piece and the mental health piece around all of that. So again, thank you. I want to move on now to our second speaker. And again, thank you to Dr. Evans. Our second speaker is Jennifer Tracy. And Jennifer joins us today to talk about RISE, the Massachusetts Mosaic Grant Opportunity. She serves as the Chief Program Officer at RISE Massachusetts Foundation, which I know many of you know is a nonprofit working on the opioid epidemic and its impact on people's communities and the economy. She manages their strategic growth and implementation of programs, initiatives that focus on grant administration, community building, and thought leadership. That's why this is such a wonderful group, because we have such a great community representation. Jen brings over 25 years of public and private experience in health and human services in very diverse settings and disciplines. Before joining RISE, she served as the director of the Mayor's Office of Recovery Services, the first municipal substance use recovery office in the United States, where she led all the substance use recovery policy and initiatives for the city of Boston. In that capacity, she served on the Opioid Recovery and Remediation Fund Advisory Council and was instrumental in developing recommendations for the expenditure of the Opioid Recovery Trust Fund to mitigate the impact of opioid epidemic in the Commonwealth. Prior to her time at the ORS, she served as the director of the Office of Youth and Young Adult Services with the Mass Department of Public Health, Bureau of Substance Addiction Services, and as the Boston Regional Manager for the Mass Bureau of Substance Addiction Services, where she oversaw prevention programs, intervention, and support services in Boston's neighborhoods. So Jen, it's great to have you with us. Thank you.
Thank you so much. And thank you for your leadership, DA Ryan. This group is, just as you said, I think instrumental in creating change, and 13 years is commendable for you to be meeting this frequently. That's the only way we do kind of see the change. So I'm so happy to be here. Let me pull up my slides. Just want to get slide deck. Can you see the slides? Okay. Sorry, just wanted to get. Okay, well, let me start. Here we go. Hi, everyone. So good to be here. I have been with RISE for about 6 months. Coming from, and thank you for the introduction, another bio that should be shortened probably, but thank you for that. And I'm here today on behalf of Julie Burns, our CEO and president, to kind of share with you the partnership, the Mosaic Partnership, which is a new grant opportunity for the state of Massachusetts to help the State Department of Public Health distribute specifically the opioid settlement dollars. So I'm going to go over the first and second round and tease the third round, which is still in process. Okay, so Mosaic is really a once in a lifetime opportunity between state and private philanthropy to come together to disperse the opioid settlement funds to organizations, small organizations and communities that have been disproportionately affected by the opioid epidemic. And the beauty really of this partnership is that we all know that the state, you know, there's a threshold of applying to state and federal grants that a lot of our small grassroots organizations really just don't have the ability to do. So DPH recognized that this was a barrier to access for communities and partnered with RISE to help disperse these dollars. Just, I'm going to run through these quick because I think we're short, but you know, we are guided, of course, by voices of people with lived and living experience in everything that we do. Commitment to equity, inclusion, and compassion. RISE is an advocate to support the small grassroots organizations and to bring them together with other stakeholders and always reducing stigma as a goal. We start out every meeting, every presentation with the reason that we're here. Mosaic is an opportunity that is grounded in hope and optimism, but it's also grounded in the recognition that the settlement funding is the result of the loss of life. And DA Ryan, you articulately presented how many, the ripple effect of just one loss. So we have created a memory wall on our website, and I would encourage anyone to take a look and share the memory of anyone you would like to be part of this opportunity to remember that every step that we do and every action that we take is carrying the memories of those that have been affected by this epidemic. So the Mosaic is a $15 million grant program over the next 3 years with 3 separate rounds. The first round was launched in the fall. I'm going to call that core. It's the community-based opioid response. I'm going to talk a little bit about that in a few minutes. The grant period is 2024 to 2027, granted in August, and that was 3.75 to 18 organizations. The second round is what we're currently in right now. It's the hopefully you have heard of the municipal matching round of grant making that we are currently doing because it closes this Friday at midnight. And I can talk a little bit more about that. That is a 1-year grant funding. So basically that is funds that RISE will be partnering with cities and towns to match the municipal opioid settlement dollars that they receive. So as we all know, there's the settlement dollars that the state receives and disperses through the ORF, and there is separate dollars that are going to cities and towns. And the third round will come out in the spring. We are still working on what that round will cover, but it's looking like it will be supporting children and families in some sort of way. And again, still being determined, and that's our largest grant of 2.5 with a total of 7.5 million. So the first round of community grant making, as I said, was put out end of the summer in September. And the primary goal was really to target small grassroots organizations and give them an opportunity to access the settlement dollars to build their infrastructure and build capacity for sustainability. We opened when I say small grassroots, this was restricted to organizations that had under $5 million operating budgets. So really targeting those smaller organizations. The grants have ranged from 16 to 150,000 annually, depending on the organization size. And again, I just want to reiterate, they provide general operating support, which we all know is extremely helpful for small organizations and very rare and hard for them to access general operating support to help just to sort of use how they for what they need rather than, for outcomes that are determined by, a funder. So just a quick brief overview of the applicant pool. So we received 97 applications and just a little bit of data around the whole process, just to mention that RISE we are evaluating ourselves during Mosaic as far as are we being accessible to organizations, to communities? How is the grant making process? Really trying to meet folks where they're at. For this round, we received 97, like I just said, the most that applications that RISE has ever received for a grant making opportunity. Because we're evaluating the whole process, you can see here that the applications were fairly evenly distributed around the region that they came from. Metro West, as you see, was the smallest, and hopefully getting the word out now on future grant making will help with some of that. And the distribution across the continuum of care was fairly even. And the organizations that applied were reaching people with lived and living experience, 91%, 74% BIPOC communities, and 73% people experiencing housing insecurity. So really targeting the priority populations that we were shooting for. We have a community review. So the applications come in, and then we have a community review with people with lived and living experience guiding the review process. For this particular grant, we had 11 teams of 3 reviewers, and you can see here 81% were represented by people with lived and living experience, and 73% subject matter. Of course, people wear several hats as well, and really focusing on health equity principles for underserved communities. Okay, next slide. So the scoring process. So all the scores come in, we average the 3 community reviews, rank them, apply another level of scoring, which takes into account opioid overdose burden and also a social vulnerability index to capture underserved communities. The next phase is that RISE reviews the applications and looks for equitable distribution across geography, organizational size, and continuum of care. And now those that were awarded represent almost every county in the Commonwealth. Actually, the only county not represented by the awards was Nantucket and Barnstable, but as you'll see in the next slide, the Fisheries Union was represented, and they do cover Nantucket. They let us know, so we were happy to hear that. The awards were evenly distributed along the continuum of care, so that's harm reduction all the way through to recovery and family support, and reaching sort of the small organizations. 72% had operating budgets below $1 million. This is the cohort of who was funded in the first round. This is a 3-year grant, and just a snapshot. This is also available on the Mosaic website for you all. There was a one Middlesex County, you can see here, to provide recovery supports. And also, so we're really evaluating this whole process. We'll be evaluating not just the grantees, but again, as I mentioned, the RISE process, and using different methods for evaluation. So just one thing to say about this core grant period, effort. These organizations, as I've mentioned, small grassroots, really need a lot of support. Many of them expressed to us throughout the grant making process that they just have never even applied for a grant, or that they were operating their organization really with in-kind support, for over 5 years. So we've provided a very significant level of technical assistance to all the grantees as part of this process, where they'll have opportunity to build their capacity with experts and others on all sorts of areas of growth. And we are learning from them what their biggest need is, and sort of altering the technical assistance to those needs. So that's that was round 1. Round 2 is closing at midnight on Friday. Like I mentioned, that is the municipal matching grant. The program will match municipal opioid settlement funds in cities and towns, and we're looking at folks that are using best practices like this task force, utilizing Care Mass resources, which is run by JSI through Department of Public Health, specifically to support cities and towns with how to utilize their opioid settlement funds. So I'm not sure if this group is familiar with them, but certainly someone else to understand the resources that they have available to city and towns. And folks that are conducting community outreach, getting feedback from people with lived and living experience, getting feedback from their community, and collaborating with other cities and towns. all projects must align with the Massachusetts State subdivision, of course. This grant round, as I mentioned, is a 1-year grant, so it will be provided once for 3 years. So if folks don't know about it or didn't come in on this round or couldn't coordinate within the timeline, we will be putting a new one out in the fall and another one the following years. So please, keep an eye out for that, and hopefully we'll expand the access to other cities and towns. The goal of this is that we will match up to $50,000 per municipality. And if you're a municipality that is joining with other cities and towns and pooling your settlement dollars, you have the ability to apply up to $150,000. So that's an incentive for cities and towns to pool their funding. Municipalities may apply directly or through a nonprofit, whatever makes more sense as to who should be the lead. We're open to that, as well as coalitions applying for a combination of settlement dollars with city and towns coming in together. Okay, let's see. All right, I'm going to go quickly here, but basically we have to have commitment from the city and towns that they are earmarking their settlement dollars for the match. That's very specific for this grant round. I've mentioned pooling money together and in the variety of folks that can apply. These are just a few examples. I think DA Ryan, you mentioned locks boxes. That's an example. So a city and town can say, we'll put up $10,000 of our opiate settlement fund. We need another $10,000 to buy materials, buy the boxes, distribute them, whatnot. That's a very good example of a project. And then there's other examples, of course, post-overdose response teams, just matching the dollars, et cetera, crisis intervention training with some of our public safety partners. And some folks are coming in for a coordinator to help steer their regional activities. So the timeline for this, as I mentioned, closes Friday. Awards will be announced in February. And the next round, okay, last slide. So the next round of funding is, as I mentioned, focused on children and family support. How exactly that will happen is being worked out right now, and it's due out spring of 2025. Happy to take any questions. This, I believe, is my last slide. Sorry for rushing, but thanks so much.
Thanks, Jen. Questions, comments? Happy to see the Bridge Club. Many of you have seen the Bridge Club. They've come in.
Marion, you're muted.
Sorry. Happy to see the Bridge Club, which we've done so much work for it, be the recipient of one of these grants. Danielle.
Hi, this is probably a very whatever, minute question. But for Jen, I come from the community of Cambridge, Massachusetts, and we are working on our application for the RISE grant. So very excited to hear from you today. We have a little bit of a problem with our city manager currently being out of town for the letter of municipal support. Does it have to be, strictly speaking, a city manager or mayor who signs it, or can it just be someone who kind of has the authority to allocate the abatement funds in our community?
Yes, you just make sure that it's signed by someone authorizing official from the city and indicate the amount in the letter.
Perfect. Thank you so much.
Great. Kathy.
I was just going to say, in Framingham, the money is controlled by the city council. So I imagine the mayor can't, or I'm not sure what would happen actually. Is there some sort of provision for that?
Yes, within the grant application, we are accepting a recorded meeting Like
Okay.
if there's a city council meeting where it's been voted on, that can be submitted where we will work with you. I think the key is just to indicate if there's some barriers, what are those? But indicate that this partnership and communication is happening between you and the city. We will allow some applications to come in if you haven't had the time to have that city council meeting
Okay.
within this grant period. And I think we're giving 3 months
Okay.
after close of grant for folks to come in with that. And if you do, then we'll move forward. If not, then, next year will be your
Perfect.
opportunity.
Perfect.
Mike-
Thank you.
Sorry, Kathy. Mackenzie.
Hi, are you able to talk a little bit more about what the next round of grant funding is targeting in terms of like family and children?
Well, so we had a design lab with some stakeholders. We're waiting for the results from that to see sort of what has bubbled to the top for gaps. And we'll be meeting with BSAS and the Attorney General's office to sort of take a look at that report and kind of follow up. I mean, there was a lot that came out in that. Sort of there's some major systems issues, as we all know, particularly with Department of Children and Families, and how that plays into to everything. And then there's also a lot of grassroots organizations that are doing family support work, grandparents helping grandparents, or a lot of supportive work that's happening out there with small grassroots organizations that isn't being supported to its fullest. But that's like shows you kind of the spectrum. So we're, kind of whittling down with this grant. We may use some of the dollars for planning as well, if that makes sense also. So I don't have the details, but I'm happy to come back when we get closer to what that might look like.
Thank you.
Anybody else? All right. Thank you. Thanks, Jen. And moving to our third speaker, I'm happy to have with us, and always good to see, Amy Rosenstein, who is, this is a very long title, the Administrative Director of the Massachusetts Consultation Service for the Treatment of Addiction and Pain. She is also the Director of Medical, Clinical, and Quality Integration at Mass Behavioral Health Partnership. She oversees the administration of those programs and leads a variety of other projects that bring together the medical and clinical teams. Prior to this, Amy was the director of the Primary Care Clinician Plan Support Services Program, overseeing a team providing support to providers in the care clinician plan, particularly around the integration of behavioral health and medical care. Amy's worked in a variety of healthcare, behavioral health, and public health organizations throughout her career, with her focus being on improving patient care, behavioral health integration, and training and education. She holds an MBA from the Yale School of Management. So, Amy, always good to see you. Thank you for being with us this morning.
Thank you so much for having me. I think it's been probably like 5 years or so since I came and talked to this group, so really happy to be back and to talk about some new things that we're offering at this point. Emily, would you mind sharing my slides? So I'm gonna call us MCSTAP, the Massachusetts Consultation Service for the Treatment of Addiction and Pain. It's a very long name. We have been operating since 2019, and at this point, we've done, I think, over 2,500 consultations. And basically, our goal is to support clinicians in their ability to use evidence-based practices, their confidence in screening, diagnosing, and treating, managing care for all patients with chronic pain, with SUD, or with both. So it's a very broad spectrum of issues that our program supports. And what we are is basically a real-time professional phone consultation service for clinicians. Our services are free, they're insurance blind, so we support clinicians calling about patients with any type of insurance. We're available Monday through Friday from 9 a.m. to 5 p.m. You can get to us by calling a phone number listed here. And what happens is somebody takes a little bit of information, our program coordinator, and then triages the call to our physician consultant who's available at that time, who will get back to you within a half hour or at whatever time you want to have your consultation. And I'll talk a little bit more about the types of things that they typically do consultations on, but it's a really broad range of topics: managing medications, a lot of pain management strategies, both planned visits and emergency situations that come up. We really cover a broad spectrum. We do consultations, a lot of them are with primary care, with physicians. We get a lot of calls from nurse practitioners and also PAs. We do get some calls from like behavioral health clinicians as well. So, we have, people with various credentials and from all parts of the state who do contact us. We have a team of 10 physician consultants and then a medical director who are all very expert in treating addiction and pain. I'll show you a picture of them in a few minutes. I'm really, really super proud of our team. And importantly, we're funded by the Massachusetts Executive Office of Health and Human Services. If you can go to the next slide. So these are just some of the types of things that we provide support on, various types of clinical issues. Treatment of patients with MOUD, we like to do and have tried to really do a lot of work to support new prescribers of MOUD. We actually have a webinar series that we've offered a couple of times and plan to do a couple of times a year, focused on either new prescribers or people that have experience and have questions. There's a lot of focus on treatment planning and medication changes, either initiating somebody on medication, dose adjustment, kind of monitoring what's going on with the patient, whether the treatment plan needs to be adjusted. Something we don't mention here, but we are periodically getting situations where there's a disruption of care in a community and there's patients who maybe have been managed by a specialist who's no longer available, and we want to work really hard with providers that inherit those patients to make them feel comfortable, because often those patients can be on pretty high doses of opioids, and maybe the receiving clinician really would like input on appropriate management. So if you move to the next slide. Yeah. So our next slide, these are examples of how we can help. There's a lot of focus on evidence-based treatment. Again, this is sort of a repeat, but support around MOUD, medication changes, developing management plans, issues about special populations like pregnant women and others. There's a lot of coaching. A lot of times people that call, really just need confirmation they're dealing with an issue. They really just want to talk through with somebody with a lot of expertise. Am I on the right track? So getting that kind of support. We do have providers that call us over a period of time about particular patients, either sequentially, like every week or every day. We actually have somebody right now who's calling in a situation where they've inherited some new patients, or maybe it's some months have passed and kind of revisiting what's going on with the patient's care. So these are just some of the ways that we help. And on the next slide, there's a couple of other things that we offer that I wanted to emphasize. If you can move to the next slide, Emily. We have monthly case discussion call-in hours that are free. They provide CME, which actually count toward the risk management licensing requirements and DEA licensing requirements. They're on a range of topics. They tend to be pretty interactive, and they're really case discussions where they focus on, a topic that comes up in consultations, and we like to have them be informal so people ask questions, and those have been really popular. I think those actually started since the last time I was here. And then a thing that I really want to emphasize is our mentoring program. which is essentially nothing that different than our consultation program, except that if there's a clinician, a MD or an MP or PA who feels like they kind of could use ongoing support, they are either new to dealing with a particular issue, sometimes people that are new to practice, new to providing buprenorphine, who would like to meet with the same consultant on a weekly basis or every other week, whatever frequency they want, but they can really get kind of ongoing support. And we've found that that's really, helpful for sort of like revisiting different difficult patients and kind of building confidence in a knowledge base. So that's something that we really like to offer and really, encourage. And then we have a resource on our website, Nuts and Bolts of Buprenorphine, which is a nice resource for just kind of some common questions that prescribers might have. So those are just some of the things in addition to consultations that we offer, and our website has more information about all of these things. If you can go to the next slide, just our team. We've had remarkable consistency in our physician consultants since we started. There's been only one change, and that was due to a very unfortunate circumstance, but the consultants have been with us a long period of time. They're very busy people, but they're very committed, and I feel like that's why they really have stayed with us for so long. A lot of mostly primary care physicians with some exceptions to that, but a lot of experience in treatment, a lot of experience teaching and mentoring, and a lot of passion. And so if you move to the next slide, I'll just give you a picture of our team, which we've got people from Boston Medical Center, UMass, Mass General Brigham, some independent clinicians. We've got someone who's at Spectrum Behavioral Health Substance Use Facility, Greater Lawrence Health Center. So we feel like they really give, kind of a good mix of the geographic health systems across the state. And then I think the next slide is my last one. Just information on how to reach us, our toll-free number, our hours. There is a link. You can actually go to our website and schedule a consultation. And that's kind of what I wanted to go through with you today and see if anybody has any questions or could think of any ways that the program could be helpful to the work that you do.
Thanks, Amy. People have questions, comments?
Please feel free to reach out at any point if it occurs to you that you're working with clinicians who could use more support, because we have the goal of continually making our, it takes a long time to build awareness, and we've made a real lot of progress, but we're always looking to, reach new clinicians and try to think about how we could be useful.
Thank you. Thank you all. And I also want to acknowledge, I see we have a representative from Representative Gordon's office here. Just another example of how this really has been a community effort. And to that end, I want to give people an opportunity, as we always do, before we close our meeting. Anything people want to share, programs they're doing, services, things they're looking for, any way this group can be helpful to others? Okay. I want to thank our providers again. I thank you all for joining us. I look forward to seeing you in December. I will tell you, as I mentioned, January will be our anniversary of really all the work here. We're planning a pretty special event for that. So more to follow about all of that. But thank you all. Be safe. Take care. Bye-bye.